Hello, my name is Joe. Welcome to the 5 Mile Difference. The name comes from something that's quite close to me. I grew up in Philadelphia, where two zip codes just 5 miles apart, the average life expectancy difference is about 20 years. And, it's not rocket science why that's the case. There's, a few variables that contribute to this, but the one that we're most focused on at Vitable is that there's just a lack of access to high quality preventative care. And so today I'm excited to have a conversation with Dr. Barron and Dr. Shaub, who I work with at Vitable. And, the conversation spans across GLP-1s, but more importantly, how we could build care delivery systems that increase access to care to the most underserved populations. Hope you enjoy the conversation. Dr. Barron, thank you for joining us. I'm excited to have our conversation. Maybe we could start off just giving a quick overview of your background, how you got into medicine, and just the evolution of your career so far, right up to Vitable.
Absolutely. Thanks so much for having me, Joe. And yeah, really excited to have this conversation. I'm Kate Barron, head of medical for Vitable. My career started in residency at Mount Sinai in New York City, where I focused on urban underserved primary care, so full spectrum primary care. Really, my passion for medicine was influenced by wanting to help the people that needed it most, and wanting to do so in a very holistic way. So thinking about a person not just for one medical diagnosis as a specialist would, but really thinking more holistically about how to improve the health of a person. And so my training focused on urban underserved primary care in a federally qualified health centers. So primarily Medicaid patients in New York City. I worked there, as well as grant funded clinics for survivors of human trafficking and sexual violence. And after residency, I worked at Rikers Island in the women's jail. So focused in on correctional health. So again, a lot of my passion was advocating for human rights and health equity, just grounded in a belief that everyone deserves access to judgment-free, empowering healthcare. And it just so happened at that time that I found my way into telehealth. I co founded a company called Hey Jane that does reproductive healthcare online. And since then, I've been focused on early stage companies, scaling early stage companies. And when I met Joe and heard about the mission driven focus of Vitable in terms of the 5 mile difference that he talks about all the time, I was really inspired by the company and have just been really excited to build this company with you all, and really excited about the access we're providing to our patients.
Awesome. And I suppose, like you mentioned, I think one of the things that has been quite striking, just, when I initially came to know you, is both, I think in digital health, we talk a lot about focusing on underserved populations that are more maybe challenging to serve. And it seems to me your Rikers experience is you sort of went to the most, like one of the more challenging environments that anyone can practice. How was that?
It was very interesting. It was also during COVID. So that really amplified the experience. And I think more than anything, it was difficult because I found that the bureaucracy of working in a correctional setting meant that I was often at the will of the correctional officers instead of being able to just focus on the whole care of the patient. Also, the jail setting in general is just a very frustrating environment because many people are there for very little reason and with very little access to advocating for their release. So outside of the medical aspect, learning more about the system itself was hard.
And I know a lot of people might not be familiar with how, at least I wasn't until I'd initially spoken to you. How does healthcare work in the, at Rikers and other, the prison system overall?
Yeah, so basically you show up to work and you work in a clinic and you have a list of patients that you want to see, and the correctional officers decide who gets to come. So, you could have a very sick patient that you want to see, but if there's a reason why the CEOs don't think that the patient should be seen for whatever reason, or they got in an argument with somebody in their housing facility, or they're just a difficult person, they might not bring them. So, sometimes people are just not afforded access in the way that you might think is typical of, any other person.
And I suppose, like, Were you generally concerned about your safety? Well, yeah. What was the typical day like? What were you feeling as you saw
Yeah,
the?
that's a great question. There were definitely times that things felt tense. So in the COVID environment, it was taking sometimes up to a week for patients to get their results of their COVID tests. So we had people in holding cells or in holding housing settings where they were waiting for their results and didn't know if they were transmitting the virus. And at this time, we really didn't know how dangerous it was, or so people were very, very kind of tense, and so it was a pretty it could be scary at times, but I mostly felt pretty safe. I had people, it was a very open air place, and most of the times I developed pretty close relationships with a lot of my patients, and they felt like very normal people.
And so you, how long were you? Did you work at Rikers for?
I think it was about 2 years that I was there.
Wow. And so after Rikers, what led you to look to leave Rikers, and then how did you think about the next step for you?
Yes, absolutely. So I was approached during my time there by a woman called Kiki Friedman, who was wanted to found a telemedicine abortion company. At the time was illegal to do so, to mail the abortion pill, and so it was really just an idea that she had as an HBS. She had was graduating from HBS and just had this idea to start this company, and she's like, hey, will you help me think through protocols? I'd love to get your insight. And so I started developing protocols for her, and one thing led to another. COVID hit, the REMS was overturned. So basically, because of COVID, this gave doctors and lawmakers an in to basically allow the legal mailing of the pill. And so that gave us an in to kind of found this company. And one thing led to another, just like how it is starting a company. You can't just do it a little bit. So it just slowly kind of took over my life. And I realized that I really loved thinking about scaling operations for the company. So it wasn't just writing the protocols, but it was managing the team and thinking about like scaling the member support team and all of the things that go along with scaling a company. I had never done anything other than just be a clinician. And I found so much joy in doing all the other stuff. And so that really led me to have kind of a newfound passion for this piece of scaling early stage companies. And when I was moving back to Texas and Roe was overturned, I had to leave the company due to legal advice that Kiki had received. So it was at that time I kind of had a quarter life crisis, thinking, who am I and what am I doing now? Because all I had done before that was be a clinician, be a doctor. And I found this niche in joining early stage companies, having the clinical background, but also thinking about the people management and the scaling the operations from the clinical side, and being kind of the clinical expert on the business side of the company. And I think it's kind of a hard thing to find. So I've found that, and I've loved doing it for our team. And I'm super excited by all the things that we're building right now.
Well, it's been really exciting to partner with you in building for our members. Going from Rikers to Hey Jane, and this, I remember seeing Hey Jane launch, and it seemed like you had a perspective on how the world should function. I'm imagining people have really strong opinions one way or the other, and especially in Texas, and it was sort of new law that enable the business to be possible. How was that? How did you handle the, being working on something so that you felt strongly about, yet some people maybe didn't quite support it and would, I'm imagining also somewhat like maybe made, could be unsafe or feel
Yeah. No, absolutely. I think for me, personally, there are definitely times that I worried about my own safety. Um, I never worried about the patient safety. I worried about my own safety, about the safety of some of the doctors that were working on my team. Some of the doctors that were working for us were at the very front lines of this movement. I've seen their names in the news in the recent years, because they will do whatever it takes. to make sure people have access to life-saving services that these are. But it wasn't always easy. I mean, being in New York City, you're kind of in this bubble of feeling like everybody is like-minded, and then you come to Texas and you realize you can't talk about a lot of things with some people. And even, as I was on this podcast, like I didn't start with saying I co-founded a telemedicine abortion company, because you say that word and people have a reaction, so I'm careful about what I say to people, and I have a high EQ, and I kind of gauge like who I can say what to, because I realize it is a really controversial topic, and a lot of people don't have the lens that I do of seeing the stories of the people that show up for this service and why it is that they need it and why it is so life-saving.
Well, uh, I'm eager to learn more and dig in. And maybe Dr. Shaub would love to, maybe we could share a bit about your background and up to the point of joining, right before you joined Vitable.
And also want to echo Kate's thoughts. Really appreciate being here. So thanks for having me. I'm Shaub, the Chief Clinical Officer for Vitable. I have a little bit of a non-traditional path to get here. So I did med school on an Air Force scholarship and was practicing in the Air Force in primary care, and had an opportunity to run the clinic that I was practicing in. And that was kind of my light bulb moment, was kind of getting my hands dirty with operations and process improvements within the clinic, and just very quickly gravitated toward that space and realized that I thought I could have a more impact by driving processes at a higher level within the clinic than when I was giving direct patient care. And so for me, that was the moment of realizing I was probably on my way towards a career pivot. And the more I dove into the operational challenges in the clinic, the more convinced I was that this was the path for me. And so finished my time serving in the Air Force, and it was decision time. Do I go the clinical practice route, or do I actually like fully dive into this career pivot? And so I went and got my MBA and fully dove into the pivot. And then coming out of the MBA program, it was kind of the follow-up decision is like, did I make the right call? Do I go back to clinical practice? Do I stay on this route? And so it ended up taking a strictly operations role that didn't involve being a physician at all. It was just kind of an added perk, but took an operations role with DaVita, overseeing dialysis centers, and absolutely loved it. And I really felt like I got core operations experience in another environment now. So now I have my Air Force primary care clinic experience, but then also this kind of broader dialysis center oversight experience with DaVita, and just based off of those two samples, like knew that this was the path I wanted to stay on. Got to the end of my time at DaVita, and I loved what I was doing, but I wanted to go smaller. I had actually dabbled in some startups in business school and realized kind of the impact potential there. And as much as I love DaVita and what they're doing, I felt like the healthcare system didn't look different from one year to the next because they existed. And I wanted to go somewhere where there was the potential to actually start changing things, the way things operate within the healthcare system. I was kind of between, do I go like a value-based care route? I also got really interested in clinical research, and was kind of toying between the two different spaces, and then talked to a company in clinical research and fell in love with the business model, and the people that I was talking to, and so ended up going the clinical research route, and like I said, mostly for impact reasons. And then actually left clinical research also for impact reasons. So it felt like I got exactly what I was looking for in clinical research. I was overseeing strategy and operations for this company, really enjoyed it. Felt like we were making an impact, but felt like there was more of an impact to be had in the standard of care space, if you will, like the non-research space. I felt like our healthcare system needs a lot of work, and I wanted to be a part of the solutions in that space. And so started looking for things that had kind of value-based care tie-ins, and like I'm incredibly mission driven. When I came across Vitable, I kind of instantly knew that this is where I wanted to be, and this was the space I wanted to be in. Also have a really personal connection to it as well. So I have a sister who she's 6 years older than me, but she has worked since high school and never had a health benefit, period, like full stop. And so, just has worked a lot of jobs where, well, all of her jobs have been such that there's just no healthcare offerings whatsoever. And so when I came across Vitable and realized that they're positioned to target this exact population, that was kind of another light bulb moment for me, where it was like, hey, I'm looking to have high impact, affordable access to care is hugely important to me, which is what kind of draws me to value-based care in general, is because we just have this like healthcare system with massive costs that's not really driving quality care. And so wanted to be a part of that solution and specifically target, the highest need folks. So that brought me to Vitable, and the rest is history. I've loved what we're building now.
Super interesting. I think your path to the Air Force, to then sort of clinical operations, value-based care at DaVita, and then the CRO company. I guess at DaVita, I mean, I know from previous conversation, that seems to have been quite a formative, and that was the first role that you took. What was that like? And maybe if you could share just a quick background on what is DaVita, and then what was that like, and what were some of the most important takeaways for you?
DaVita, so just kind of background on the company, they're one of the two biggest dialysis providers in the U.S. They have, I think, 4,000 clinics or so across the country. What it was like was I felt initially kind of like a fish out of water. It was like I had this ops experience in the Air Force that I had been really excited about, but I felt like the experience at DaVita was just radically different. Like in the Air Force clinic, like the clinic is the whole world, and like I got to be a decision maker there. And so it was like I started, right away, day one, kind of looking at patient feedback, and it was like, oh my gosh, people hated the clinic, by the way. And so it was like, what levers can we pull to like improve this patient experience? And I actually like had the ability to pull those levers. So we like totally changed the way we did scheduling, and we stood up like an acute care arm and a chronic care arm, and we built out kind of these remote clinics in different places on base, and leaned into telehealth, and it was just awesome. And I felt like I could make the decisions that I needed to make to like drive the impact that I wanted to drive. And then like we had phenomenal patient experience, like patient feedback like 6 months later was awesome. And so it was like kind of riding this like really cool operations high. And then I got to DaVita, and it was awesome, and I love my experience there. But it was I realized like how much more difficult it is when you aren't like the decision maker, And so I had to kind of learn how to subset like the impact that I wanted to make specific for my region, and then like how do I then roll that up into like bigger processes within the org and at a division level, and then like try to roll up beyond that. So, and I also kind of realized the like people get siloed very quickly in large orgs. And so, believe it or not, even though the Air Force is a huge org, I didn't experience that as much because I was at a smaller base. And so it was like very easy for me to like pull in the right people into the right conversations and get things moving, versus at DaVita, it was like there's a department for everything, and those departments don't necessarily move quickly. And so like you would want to make a decision, you'd have to figure out who the decision makers were. It would take forever to get them coordinated and like in the same room together, and you probably wouldn't even get them in the same room actually. And then like it would take a while to actually get things to move forward. So my pain points there were like kind of around the size of the org and this like silo process, and just like knowledge transfer not being super efficient. But some of my learnings were that you can build, when you do build a process that works, it can be like really incredible. And when you build something in like a small scale, and then you like scale it up to like a larger subset of the org, it's really cool to see the impact there. So like an example that I'm thinking of is we had patients who just like didn't show up for dialysis treatment, and you would think that that's not like something that you would come across, but it's actually very common. Like you have a lot of people who miss dialysis appointments. And so, coming into DaVita wasn't something I realized was an issue, and then got there and realized it was a big issue. But there were clinics in the area that had started these like incentive programs, if you will. I'm careful about the word incentive because in the dialysis world, it's like kind of a really like it's a word that has like a lot of red tape around it, and you have to be really careful. And so there's like very clear restrictions on like how you can incentivize patients, but there are guidelines that you can follow, and we followed those and actually stood up programs that like allowed people to enter raffles if they had like quote unquote perfect attendance for like a month's worth of dialysis appointments. And then you would like raffle off like a blanket or something that fell below whatever that like value threshold was, to not be like too strong of a patient incentive. it was radically impactful. These programs were like, it was ridiculous how much they improved adherence to someone's dialysis treatment schedule. And so my big takeaway was like, I got to see that happen on a small scale, and then I got to see that roll up and become bigger and become divisional and become multi-divisional. And it was just like a really, really fulfilling experience to see that even within a larger org, like things can kind of materialize at a smaller level and then like expand across the org, and you can have really big impact. Sorry, that was a really long-winded answer.
That was really great. I really appreciated the example, because I think what you mentioned around people might not expect dialysis patients to miss an appointment, but it does happen. And you talked about designing incentives. How could you provide ways to make it easier for the patient to make the decision that would be a net positive for their health? And for those that are not aware of DaVita scale, could you give just a quick overview of how large was DaVita? Any other context that might be helpful just around the scope and where they sit in the overall healthcare system?
Sure. So, I mean, they're like a Fortune, I think, 20 company. I wouldn't be able to say kind of off top what their total revenue is as a company right now. I would have been able to a couple years ago, but it's about 4,000 clinics. My region alone was about 100 million in revenue. So that for context, and that was across about 15 or so clinics. And so that, I think that gives a little bit of context for the size of the org. They're very big. Does that answer your question?
It does. And so, as you went from DaVita, you had the Air Force experience, and you were thinking about, you also had the business school experience, sort of fusing the clinical training with the operations background. What were you optimizing for as you thought about, I know you mentioned impact, but and value-based care, but as you see it, what are the sort of problems within healthcare, given just the scope of experiences that you've seen? And I suppose, what do you think are the viable solutions?
Yeah, for me, cost, quality, and access, and it's like very clearly, those are the issues that I see. And so honestly, like when I was leaving clinical research and even going into clinical research, I didn't know how to like fully optimize for those things. Like those were the things that were important to me, and I knew that I wanted to like help build out a model that targeted all three of those things. But like it's hard to find a model that targets all three of those things. And maybe you find one and it's like it's a good idea, and then there's no real business model behind it. And so it's like you have to add in this like profitability piece, right? It's like you need to like, you can target cost, quality, and access all you want, but you have to do it profitably to actually make an impact. And I think that's where a lot of like good idea healthcare companies fail, is like in the actual like implementation and org structure and operations. And so for me, I think I landed on a company that I thought was more operationally sound, and so for me, and in a space where like I loved clinical research, but I thought like there was more impact to be had elsewhere. And so again, that's kind of what drove me to the Vitable path. But when I came across, so I was kind of looking for like, hey, what's the next move for me? And these are the things that are important to me. And when I came across Vitable, I thought like, well, here's an opportunity. Like I had already kind of fallen in love with DPC in general. And then like a DPC that is like literally targeting an underserved population, but an accessible underserved population, right? Like they have employers. You can go to this underserved population through their employers. That to me was like, oh my gosh, that solves like such a huge barrier, because like now the access piece is less of an issue. If we can get in here and do this right, like we can push the cost to the employer as long as we still make it affordable. Like now we've actually solved the access problem for this underserved group of people. And so for me, that was kind of what sold me on the Vitable model, was like, here's the underserved population we want to target, and we have access to them. So now the real question is, can we like actually build out this high quality care experience that is affordable for the employer still, and then do it in an operationally sound way where we're still profitable and can continue to scale. And I kind of accepted that as like, hey, that's the challenge. Like that's what I want to do, and I would love to be a part of that solution and help push that forward and do like literally do that exact thing. Build out high quality care programs, make sure that we are targeting affordability as we do so, and like keeping our target audience, our target population in mind as we build these programs out, and keeping affordability at the forefront and quality. So I kind of accepted that challenge when I joined Vitable.
I think you touched on, which is a great segue, oftentimes access being the barrier to I think most companies in healthcare would aspire and claim to want to increase access to care. you know, I think it's a good aspiration, but increasing access to high quality care, it seems to be how do you not just scale like a lower quality or like, maybe a subpar experience to an underserved population, but how do you deliver something good, that they do use and it has, um, accessible barriers of entry. And so maybe Dr. Barron, you've helped us go from one state to 50 states, serving maybe 100 employers and single digit thousands to tens of thousands of members now. And you continue to actually spend time and see patients and inform the clinical programs that we launch for our patient population, which are mostly blue collar workers. As you were joining Vitable, what stood out to you, and then what are the things that how is Vitable sort of patient population and their unique needs informed how you think about the healthcare system, or just overall like how we should approach as a not just as a company Vitable, but more of a as a clinician.
That's a great question. I think our patient population is really very similar in a lot of ways to a lot of the folks that I worked with in federally qualified health centers, but they have access to this really high quality, high touch, affordable, accessible. And when I say accessible, telehealth is just, I mean, it opens up so much for people. Getting to an appointment for so many people is really difficult. So having access to super high quality providers online, on demand, same next day for folks that often either don't have insurance, the access they have is you are waiting hours and hours to just be seen for a visit. The clinic that I worked at, if you had an appointment with me, you were waiting 2 to 3 hours to be seen for a 15-minute visit. And now I am seeing the same patients online. They can schedule with me on the same day or the next day. I can see them for virtually anything, and they get their medications for free. They don't have to wait to see me, and they get the same quality of care that they would have if they were seeing me in that. So I think that is groundbreaking, and really, I mean, it's the future, right? I mean, these folks normally just might not have access to healthcare at all.
And I think we do at times feels quite simple. It's sort of like we know what great healthcare looks like, and it was mostly tailoring it for this audience and maintaining the same very high bar for quality. Um, when we started working together a few years ago, GLP-1s weren't necessarily in the mainstream as they are now. But many of our members are diabetic, and we'd often talk about how to find ways to better support them. GLP-1s have exploded in popularity, but maybe if we can start with the basics, what are they and why are they so effective for weight loss and diabetes management?
Absolutely. So GLP-1s mimic a natural hormone, glucagon like peptide 1. So they are agonists to that same receptor. They help regulate blood sugar and appetite. So they were originally developed for type 2 diabetes, but they were found to significantly reduce hunger and slow stomach emptying. So researchers and providers found, I started these patients on these medications for diabetes, and then they found that they were losing all of this weight. So the way that they work is they actually mimic the hormone that tells your brain that I'm full. So they help people feel full faster, and then they eat less, of course, and then that leads to less conscious restriction. So they reduce hunger and cravings, so people tend to eat less without feeling like they're constantly fighting hunger. So like if you're on a diet, usually you're feeling this psychological pain of having to restrict and not eat when you are trying to fight these cravings, which these medications kind of prevent those feelings. So medications like semaglutide, also called Ozempic or Wegovy, and tirzepatide, Manjaro, or Zepbound have shown major weight loss compared comparable to bariatric surgery. But of course, and I think we'll highlight in our conversation here, they're not magic. They work best in kind of a more holistic, like high touch approach when they're combined with healthy habits, and when you have a kind of provider that's looking at your whole health and doing a lot of counseling and support that can lead to long-term weight loss and long-term healthy habits. But I definitely think that GLP-1s are, have opened up an exciting new chapter about how we treat obesity. Ash, do you want to add anything to that?
Honestly, I would echo everything that you said there. I think GLP-1s are massively, massively impactful. So much so that the FDA essentially declared like a public health urgency when they enacted the shortage. So for those who don't know, so the manufacturers couldn't keep up with patient demand, and it was very obvious how effective these medications were. And so the FDA declared a shortage, and by doing so, it allowed compounding pharmacies to make copies of the medications and like massively improve access for a lot of people because the prices were so much lower through these compounding pathways. That and that's because those compounding pharmacies don't have to make up for production costs or like developmental costs that the manufacturers are trying to recoup through the higher pricing. But the end result was a huge change in access for patients, and like the standing up of a ton of business models built around these like cheaper compounding pathways. But anyway, my point with saying all that is I think the effectiveness is very clear in the fact that like the FDA would even declare a shortage like that, because that was just rooted in the fact at this point that they're highly, highly impactful, and so much so that it's worth kind of going this non-traditional route of shutting down the standard process around like infringement of IP and allowing these copied versions to be made to meet the demand.
I know there's been a lot of chatter and maybe criticism of some of the telehealth companies that have GLP-1 programs, and they've grown incredibly fast because there's just a lot of patient demand for GLP-1s because of how effective they are and helping them. Just how effective they are. What is it about those so-called pill mills that maybe, because I know we've talked about this as a team. What is it about the pill mills that maybe concerns you, or that maybe is a net negative for society overall? And maybe starting with Dr. Barron.
Yeah, absolutely. So I think that, just like any medication, GLP-1s are not without risk, right? So they can't, of course, the medications can be super helpful, but they can cause a variety of things. They can cause side effects, nausea, vomiting, diarrhea, constipation, worse if doses are increased too quickly. So, of course, most of the time these side effects are manageable, but they can be more severe in some cases, especially if people are started on too high a dose or increased too quickly. So in this way, a service like Vitable, where we're following up with patients for video visits, carefully titrating their medications on a patient, like on an individual level. So we look at the patient. It's a patient specific dose schedule. We're not kind of just broadly deciding, oh, everybody's just going to get this and we're just going to increase their dose after 1 month. We're instead going to look at the individual patient and say, how are you doing? What side effects are you having? Are you ready to go to the next dose? And that sounds simple, but I think just having a very kind of more patient-centered approach to how we're titrating the medication. Of course, we have to also screen out what are some contraindications. There are risks that are less common but more serious. They can cause pancreatitis, gallbladder issues. They're contraindicated in a specific thyroid tumor type. So, of course, having a very careful medical screening before starting the medication is also important. So just as a direct primary care service where we're really looking at the whole patient, their medical history, and not just like as a contraindication, but also to say like, I can also treat your hypertension. So I think that's such a cool part of this is that we're screening for the things we have to ensure they don't have, but we also are able to provide them care for the other conditions that might come along with obesity. The other piece is monitoring, which I've kind of nodded towards, is that we need to monitor their labs and vitals regularly. There are many pill mills that don't even check labs before starting medications at all. So we're going to be doing a much more kind of patient-centered approach of checking their labs before they start and making sure we're monitoring that so we make sure they don't have an effect on kidney, liver, things like that. And then, I think the other big piece is just, yes, these medications can be effective for weight loss, but what we really want for our patients is long-term health. So let's make sure that we are thinking about a long-term plan in terms of lifestyle modification to support long-term weight loss and health rather than a quick fix. And so I think that coming through a service like us, we can foster that long-term relationship that will lead to long-term success.
I suppose like of people, there's a subset of people that maybe feel strongly against GLP-1s and say that behavioral change is much better and more effective in the long term than sort of like having folks rely on medication. And there's an approach that's, some companies argue it's a combination of both. And so maybe Dr. Shaub, in this spectrum, these sort of two ends of the spectrum, how have you thought about that?
Yeah. Behavior change is incredibly important. In fact, there's people who would say like, "Hey, behavior change is everything." I would agree with that. But if you have a highly effective supplement to behavior change, why would you not use that? Especially if you can do it safely. So I think like the view right now has been a little bit clouded by these like unsafe practices that we've already called out, and these like pop-up clinics that are doing this like not the way that it should be done. And so if you have a high touch approach where patient safety is at the core, and you have a medication that requires that high touch approach, but if done using that approach is incredibly impactful, like so impactful that it's comparable to bariatric surgery, as Dr. Barron mentioned earlier, why would you not include that in your care path for these patients? And if you do that and you pair it with behavior change, you get a much better impact than either one alone. And then there's a clean handoff at the end that actually is from the medication to the behavior change. So like the end result is not stay on this forever. I think there's a subset of patients that probably is the reality, and there's already people talking about like low dose protocols and can we use them long term. So I don't want to say that as a blanket statement that people won't stay on these forever, but I think for a lot of the population that we're targeting here, that's not the initial goal. It's like, oh hey, you're going to go on this medication and you're just always going to be on it. The idea is like, let's get you the weight loss and pair it with behavior change, and then we can do this kind of clean handoff where we start pulling back the medication, make sure you have the support and the behavior change skills to maintain that, and then kind of like slowly come off of the medication and keep you where you got to with the behavior change piece alone. So I think like the pairing is just radically more impactful than either one alone.
And I know we think about this often as we consider what to add to our direct primary care plan, but there seems to be, because of the proliferation of these GLP-1 telehealth services that will run an async survey, prescribe the medication, patient picks it up. It feels like there's little continuity of care or actual primary care, and more of a, you're paying for the prescription and then going home and self-serving. Given the number of people that have tried this, everyone sort of now knows someone that has had some adverse effects as they've self-served without any continuity of care, of connection to a primary care provider that's helping them manage them. And, largely because the primary care providers maybe don't have access to the same system that would make it as convenient for the member to get access and to the medication. Dr. Barron, you're speaking to our members every day and also working with the providers as they think about ways to better serve our members. And we know some of our members have gone on and used some of these services. How did you balance between the increasing access and for our members, like doing it in a high quality way that we'd be proud of, and we'd feel that it did meet our bar for quality, given just that, it seems like the bar for GLP-1 pill mills is set quite low.
Absolutely. Well, first I'll just say that before we were offering this service, I can't tell you how many times I just had a patient come on and just say, I want those medications. I'm like, I'm sorry, we don't offer them. So people want the medication. And the only thing I'll add to what Ash was saying earlier is that the other piece of why, GLP-1s should continue to exist is that it's not as simple as saying like, I want to lose weight and then you just go lose weight. Like a lot of people attempt to lose weight many, many times and are unsuccessful. So that's one of the things that we consider when we're evaluating like eligibility criteria for the medication is to say, not any person that walks in the door can get the medication. You have to meet the specific FDA kind of requirements that dictate what reason why somebody would qualify for these medications. So I think that in and of itself is different than a lot of these pill mills. People are using these medications off label for many different conditions, or someone might qualify with kind of like a lower bar than what we're setting. So I think our eligibility criteria one is fairly conservative. I think that, you kind of mentioned this is that, so we are not only offering the high touch setting of having somebody do a video visit to ensure they're eligible to do the initial screening, but we also are ensuring the continuity for that member. So that member will continue to see the same provider, which I think will also develop trust in that provider, which we know increases adherence, increases success, all the things that come along with continuity. In addition to that, we have the full kind of spectrum of our direct primary care offerings. That means access to our mental health services. That means access to all the primary care services that we have, as I mentioned before, hypertension management as an example. If you need birth control, we can also give you that. So I think having this individualized approach where we're looking at every patient and saying, what is the plan that you need, not just like a one size fits all, really sets us apart from the pill mills.
And so long term, we talked about behavior change and fused with GLP-1 medication. So for instance, my dad is diabetic and he struggles to lose weight. And as much as the doctors recommend not eating as many sweets and carbs, on Father's Day he absolutely had some sweets and carbs, and behavior change is quite difficult. But is a thought that patients like my dad would be on these medications for this would be a part of their routine and a way to self-manage. It seems like there's different perspectives around this, and your consensus is still developing. But curious how you both think about this now, and maybe Dr. Shaub going first.
Yeah. I'm actually really glad you asked this because I thought of something while Kate was talking, actually, and it's that, like, I highlighted earlier that behavior change can like supplement the GLP-1. What we didn't talk about is that the GLP-1 can supplement behavior change. And I think that's an important thing to state, and I can explain why. It's, how many people have been told to lose weight? And you have the perfect example with your dad, right? Your dad has tried to lose weight, has tried to do things, and hasn't felt like he's been able to move the needle, and he gets like deflated probably very quickly, and then it all fizzles out, all the momentum is lost. How much radically different of an experience is it when you start doing these things and you see immediate gains? You actually see, like, oh my gosh, like it's working. And so you get people who are like very positively motivated early on because the GLP-1 is helping supplement the changes that they're trying to make. Your body's also pretty resistant to losing weight sometimes. If you've had the same weight level for a long time, your body has like a set point on weight, and so it becomes really difficult to like actually move that needle. And so the GLP-1 is helping them move the needle earlier and motivating them, and then the behavior change takes root stronger. So I think like we hit on the reverse pathway really strongly earlier, but I think it's really important to also call out that the GLP-1 actually helps behavior change in the long run. And so to your question, like, I think you're right. We're figuring out what it looks like and what the long-term pairing is. And there probably is some low dose protocol out there that becomes more of like a maintenance dose for a certain subset of people. But I definitely think there's going to be a subset of people who we do get on these medications. They have very strong results in combination with behavior change, and then they end up off of them for the long term. And the behavior change was able to like really take root largely because of the early wins they got from the GLP-1. And then the GLP-1 is also supplemented then in the long term by that behavior change. So I think it's a really great pairing, and then eventually you can remove the medication for at least a subset of people, and I think that will be the long-term reality.
And just like that dovetails perfectly with like with the individualized approach, right? This is not a one size fits all thing. I don't think we can say across the board everybody should stay on maintenance or everybody should be weaned off. Like when I spoke with our providers that have a lot of experience providing this care, that's exactly what they said to me. They said sometimes you wean them off and sometimes you don't. It's completely dependent on the patient. But how cool is it to have a provider that you really trust and that you get to know, who knows you and your social circumstances and your cultural setting, and what more likelihood are you to adhere to your dietary plan if you have a provider that believes in you and that you trust? Our provider, I'm not going to say her name because I don't know if she would want me to, but she's one of the lead clinicians on our team, a Black woman who, has patients that she has she was written up in to be one of the Black NPs recognized as an honor for helping a patient, brought her to this organization to say she has helped me lose all this weight. And so much of it was because she felt that she connected directly with her because of her cultural background and her ability to see the patient, and understand her cultural circumstances, and give her lifestyle modification because she understood her cultural circumstances and it wasn't somebody else that was kind of telling her something that didn't really resonate with her real social setting and what her life was and the foods that she's exposed to and all the things that come along with it. And she was successful because of that connection. So I thought that that was really, really cool.
And what you just described is like so much different than here, follow these instructions. Like here's a behavior change like worksheet. Like go do these things. Like that's what we mean when we say high touch.
Yeah, and I think I think one of the things that's at least with our integrated model, where, and I think we've seen this with mental health, where it's sort of mm, we're the first place that members come when they have any healthcare need, whether it's to get their, like you mentioned, Dr. Barron, their birth control medication or whatever sort of like, common medication that they have as a part of a prescription program, or they have a more acute sort of need that they're seeing through the virtual care program, or they have a mental health need, or I guess in this case, GLP-1s. We're the one place that has all of these data points as well about their previous encounters and their health. And because we have the context around, I'm imagining that powerful in one, building just empathy on like, the best intervention for that member, and the continuity of care. But the encounter about something unrelated to GLP-1s could be an opportunity um, to reinforce the behavior change. Do you see that often? And even before we started launching the GLP-1 program.
No, absolutely. I think that I've kind of implied the answer to this in some of the other things I've said, but I think having the full context of a patient completely changes outcomes for our members. So understanding the full picture of their mental health, their social circumstances, as well as all the comorbidities, kind of allow you to make real change and affect a member's long-term health.
Awesome. Well, thank you both for making time to chat today. If you could leave listeners with one takeaway about GLP-1s and safe prescribing, what would that be?
So I think what we've kind of alluded to throughout the conversation is that GLP-1s can be super effective, but they're not a magic bullet. They also require that you think about the whole picture and focus also on behavioral change and lifestyle modification. So in our high touch environment where we can focus on a trusting relationship with the provider that ensures continuity, regular monitoring, side effect management, and long-term success, I think that this really sets us apart from the other services out there.
My takeaway, Joe, would be actually kind of piggybacking off of what you were just talking about with kind of knowing the patient's entire journey across different providers. I think like that is the thing that really sets us apart, and I think it's a night and day patient experience. Like with us, they're not just getting a shot, they're getting context. Like we know if they're diabetic, we know if they're hypertensive, we know if they have anxiety issues. We help manage all those things together, and I think it creates a very unified care experience that compares very favorably to the fragmented care that they would get. And this allows us to drive better outcomes. So I think like when we talk about high touch and integrated care experience, this is what we're talking about. And it's really creating an ecosystem that people want to interact with. So that ecosystem, if you create that and people want to interact with you, all of a sudden your ability to drive utilization and adherence goes way up. And then that improves your ability to actually drive outcomes. And so, we talked before about, all the different things that can go wrong and some of the risks involved in this type of program. And the risks that lower touch orgs are running when they have the more like the lower touch system built around this. But I think for us, like an important thing to call out is like those risks, that's detrimental to the patient, but that's also detrimental to the cost of care. And so like when you have this integrated care experience that really is taking care of the whole person, you are also like mitigating risk in a way that is going to drive costs down in the long term. And so I think like, it's really like a full picture that is going to help both the patient and the organization that, that you're partnering with. So I think that's kind of what sets apart a high touch experience. And I think that's my big takeaway for the audience.
Well, thank you both. Really appreciate you making time to chat. And really excited to launch this program. I think I know our it's something that our members have been really looking and leaning to us for. Yeah, thank you both.